that's also okay, just to say who you are and your got 2 people waiting in the lobby. Sam, would you be able to? Okay, so I believe we are recording now. So welcome to the inaugural meeting of the Leeds Committee of the West Yorkshire Integrated Care Board. This is being held remotely by Teams, but members of the public have been given the opportunity to request a link. However, as yet no requests have been received. The recording will be made available following the meeting, and we'll aim to close the meeting at 4:45. We're going to have a short break at 3:30, at which point we will ask members of the committee to put their cameras off and have their microphones muted. So as an introduction to our first public meeting, we're going to show a very short video in relation to our partnership journey as an integrated care system. And I haven't seen this video either, so I'm looking forward to watching it with you. Who is going to put that on for us?
I'm just doing that now.
Excellent, thank you.
Yeah.
And then we'll introduce ourselves afterwards.
Mamraj, we can't hear the video.
Okay. Try that again. Is that better? Yeah.
Thank you for all you continue to do. Since 2016, you have played a huge part in our successful West Yorkshire Health and Care Partnership journey. And together, we've reached our new destination, a new statutory organisation. We will continue to provide joined-up care to help people stay healthy in our 5 local places. That's Bradford District in Craven, Calderdale, Kirklees, Leeds and Wakefield District. We work together in neighbourhoods with place partnerships and provider collaboratives within the NHS, social care, Health Watch, voluntary community social enterprises, hospices, charities and communities. Every day you help to give everyone their best start in life, with every opportunity to live a long, healthy, happy life. Together we have battled the global pandemic, delivered care in hospitals, communities and people's homes, and supported people to return home from hospitals as soon as safe to do so. As a partnership, we support those living in our local places. A lot of people need our help. Everyone is important. Some are facing the biggest health inequalities in the country. We know some people die sooner because they have learning disabilities, a long-term health condition like diabetes or heart disease, are from minority ethnic communities, or have complex mental health problems. When we work together, we can better meet people's mental, physical and social needs by helping to prevent ill health. There are 2 important elements of our partnership: a new integrated care board organisation, our formal statutory organisation, and an integrated care partnership. We call this our partnership board. They produce plans together. Our integrated care board is responsible for around £5 billion of NHS money. This is an evolutionary change for us. We are now defined by law, and 1,300 of us are also employed by the integrated care board. As a statutory organisation, we can remove barriers in providing better, more joined-up care for our people and communities. We can also spend our money and use our staff time wisely together. It also means our local partnerships will flourish, which is part of our purpose. We're driven by our founding mission, values and behaviours. We take a distributed leadership approach, which means local place-based health and care leaders can make key decisions to meet the needs of local people. We think this is important. Before we go into what our new organisation means for you, here's a reminder of some of the fantastic work we've all done to improve people's lives. Delivering the biggest vaccine programme in history, delivering on our Big 10 ambitions, These from increasing the years of life that people live in good health and addressing the health inequality gap for children living in the poorest households, to strengthening local economic growth with partners and reducing the number of antimicrobial resistant infections. Investing 12 million in independent social care staff to retain skills and deliver vital community care. Investing 1 million to keep people warm in winter. Our Healthy Hearts initiative supported 12,268 people who had undiagnosed atrial fibrillation and 6,707 people at risk of stroke. Working together to look after our neighbours. Delivering on our suicide prevention strategy across West Yorkshire. Supporting working carers so they can continue in their caring role. A memorandum of understanding with voluntary and community organisations because they are equal vital partners. We've invested in digital technology to reach more people, to work differently, whilst also recognising that face-to-face is still very important. Winning the Integrated Care System of the Year Award from Health Service Journal in 2021. And what does it mean for you? As part of our partnership, you make a huge difference to people's lives in our local places. We want you to feel as proud of this as we are of you. Our non-executive members, Healthwatch and Communities, here to help us with independent scrutiny, work together with us to make a real difference and build on the excellent work that you and other colleagues have delivered. You are also one of around 100,000 people working across our wider health and care partnership. We would like to thank all of you as we enter the next stage of our journey as an organisation, where all are appreciated equally. As an employer, we want to offer rewarding roles that support your well-being and where your contribution is valued, because without you, we couldn't deliver anything. Everyone in our partnership family are true partners with a shared purpose. We're looking forward to the future. We're proud of our partnership and we're proud of you.
Well, thank you very much for showing that. I thought that was a really informative video. So any comments on that or any particular points to raise? If not, I think that was a good way to start our first meeting. I'm now going to invite all of the members of the board and the committee to introduce themselves, their role on the committee. So I'll start with myself. I'm the independent chair, and we have independent members on the board, and that means that we aren't affiliated to any organisation in the city, in the system, and so we can act independently across the whole system to help to provide support and challenge to the new arrangements. And I'm the chair, and I'm very grateful to be appointed and looking forward to working with everybody as we move forward in this exciting new world. So I'll go down my list at the side. If I could invite, we have a couple of people who are observing the meeting who can also introduce themselves if they so wish. And the first person I have is Philippa Bird.
Hello, yeah, my name's Philippa Bird. I'm a public health registrar working in the public health team at the council, just observing the meeting today. Thank you.
You're very welcome, Philippa. And the next person I have is Jason Brock.
Hi, I'm Jason Brock. I'm a GP. So I'm one of the medical leads that works with Tim, and my key responsibilities are around innovation and informatics.
Thank you, Jason. And I've got Cheryl Hobson next.
Thank you, Rebecca. Hi, my name's Cheryl Hobson, and I am the independent member of the Leeds Committee of the West Yorkshire ICB, chairing the Finance and Best Value Subcommittee.
Thank you, Cheryl.
Very much looking forward to working with the committee.
Excellent, thank you. And Victoria Eaton.
Afternoon, everyone. Victoria Eaton. I'm here as Director of Public Health, as a member of the board, and very much looking forward to joining up the work of the board with everything we're doing across the city around public health. Thank you.
Thank you, Victoria. Anne Ellis.
Yeah, I'm Anne Ellis. I work with Sam in the corporate governance team.
Thank you, Anne. Francesca Wood.
Afternoon, everyone. I'm Francesca Wood. I'm here substituting for Shanaz Gull, who's the third sector representative. She's had to take early maternity leave. So I'm here for this one session only, representing the third sector.
Thank you very much, and we all wish all the best to Shanaz, who has started a maternity leave on birth of a child. So congratulations to her. Hannah Davies.
Hi, I'm Hannah Davies, Chief Executive Health Watch Leeds. I'm not a member of the committee, I'm just here for an agenda item.
Hi, very welcome, thank you. Jo Harding.
Good afternoon, everybody. I'm Jo Harding. I'm Director of Nursing and Quality for the ICB in Leeds, and I'm also the Leeds place-based lead for quality for the West Yorkshire ICB.
Thank you, Jo. Julian Hartley.
Hi, everyone. It's Julian Hartley, Chief Executive of Leeds Teaching Hospitals. Delighted to be part of the board, and I also chair the West Yorkshire Association of Acute Trusts, which is the acute provider collaborative across West Yorkshire, and great to be here. Thanks, Rebecca.
Thanks, Julian. John Beale.
Good afternoon. I'm the Health Watch representative on this committee. I chair Health Watch Leeds, and professionally I'm a retired consultant in dental public health.
Thank you. Manraj Kayla.
Good afternoon, Manraj Kayla, Head of Partnerships. I'm here in a support and advisory role, working alongside Sam to ensure the governance and other infrastructure runs smoothly for the partnership.
Excellent, thank you. And representing Thea Stein is Brian Machin.
Yes, hi everyone, Brian Machin, Deputy Chief Executive at Leeds Community Healthcare. Thea sends her apologies.
Thank you. Chris Mills.
Hi everyone, Chris Mills, GP and Chair of the Leeds GP Confederation and Chair of one of the population boards that sit under this, the Fraser Population Board. Thanks.
Thanks very much. Sarah Monroe.
Afternoon, everybody. I'm Sarah Monroe. I'm the Chief Executive of Leeds and York Partnership Trust, and I also lead for workforce in the city and chair the Provider Collaborative for Mental Health and Disability and Autism for the West Yorkshire Integrated Care Board.
Fantastic, thank you very much. Visa.
Hi, good afternoon. I'm Visa Peshan-Sykes. I'm the Finance Director for the Leeds and Care Partnership, Health and Social Care Partnership. And I've been in Leeds for the last 14 years.
Great, thank you. Wonderful. And Sam Ramsey.
Hi everybody, Sam Ramsey, Head of Corporate Governance and Risk, supporting the committee and the subcommittees.
And Kath Roth, I think, is next.
Hello everyone, Kath Roth, Director of Adults and Health for Leeds City Council.
Thank you very much. Lovely to see you, Kath. And Tim Riley.
Hi, Tim Riley, Accountable Officer Leeds, as a member of the ICB team in Leeds.
Great, thank you. Kirsten Wilson.
Hi, I'm the Head of Insights, Communications and Involvement at the ICB in Leeds, and like Hannah, I'm not part of the board, but I'm here today to present.
Very welcome, thank you. And Yasmin, I've got Yasmin Guest as your name.
Hi everyone, I'm Yasmin Khan. I'm an independent member of the Leeds Committee, and then I'm also the chair of the Delivery Subcommittee as well.
Thank you very much. That's excellent. Yes, we and 3 independent members, including myself, and we all chair a subcommittee. Mine is the Quality and People's Experiences subcommittee as well. And we're all delighted to be here with you all, I'm sure. So we'll go to apologies next, which we've had from Thea Stein and Shanaz, and we've had those noted already. And the people who are representing them, deputising for them here, have indicated that. So could I just move on to declarations of interest? Does any member have a declaration of interest they'd like to alert to the board? In the future, we will have a register of interest circulated with papers in advance of the meeting, but just this meeting, if anyone wishes to verbally update, please put your hand up. I can't see anybody, so I'll assume that's there's no declarations of interest to raise. So going on to item 3 on the action tracker. Members can note the updates provided in the tracker. Some of those will be discussed during the meeting, and a more formal tracker will be put in place following this meeting going forward. But would anyone like to raise anything on there that's not on the agenda? I can't see any hands, so I'll assume that's okay. Thank you. Okay, so item 5, questions from members of the public. There is an item on the agenda, standing item, where questions can be raised by members of the public. We haven't had any questions raised today, so we're going to move straight on. However, in the future, if there are members of the public you're aware of who would like to raise questions with us, please do encourage them to submit those, and we would like to have good public representation at the meeting should they have any queries about the work we're all doing. So we'll move on to item 4, which is people's voice. So we're starting our meetings with a lived experience of health and a personal experience of health and care services. We want to start with people in everything we do. So this is a good reminder for us all about how we make sure what we talk about and how we decide things is affecting people. So I'm going to hand over to Hannah, who is the Chief Executive of Health Watch and has introduced herself already, to take us through this.
Great, thanks, Rebecca. Yeah, as Rebecca said, we know as a health and care system that it's vital that the voice of experience and people, sorry, the experience and voice of people is runs throughout our health and care decision making. Starting a meeting is just a small component of that, but actually really important in terms of framing our discussions. And the idea is as you meet as a committee that we really tailor the lived experience bit to the agenda. For this one, though, we're working with our How Does It Feel for Me balanced scorecard work. And I will just give a quick introduction to that because there are new members of the committee who won't have heard about that programme before. In 2018, the CQC came to Leeds to do a system-wide review of Leeds, and they asked a really good question. They said, how does it feel to be an older person moving across health and care services? And actually, we couldn't answer that as a health and care system because we didn't understand people's experiences as in terms of whether they were joined up or not. We understood individual journeys at the council or the hospital or within a GP, but we didn't understand that journey. So since then, we've been doing a piece of work, and that's a system-wide piece of work. So all the organisations represented here are part of that working group, and I chair that as Chief Executive of Health Watch Leeds. And together, sponsored by Kath, we've developed what's called a balanced scorecard approach. There are 4 different elements to it about how we as a health and care system understand people's experiences. The videos that we're showing today are just one element of that, but actually they've proved very effective at giving a real insight into whether or not care feels joined up or not. The story we're going to share today is we've been following Adam and Emma. And they're 2 residents of Leeds, and that's part of the video programme is we follow real people's experiences and stick with them over a period of time to understand how it feels. We can circulate the previous videos from Adam and Emma for those members that haven't seen them, and hopefully you'll find them. I mean, they are just fascinating. Adam and Emma could be Gogglebox stars. They're that sort of engaging. So I'd encourage you to have a look. But they work best, the videos work best when they're watched together as a group, because then it allows reflections, and very interestingly, people see different things from the videos. Just to finish though, out of this work, and not just the videos, but the wider balanced scorecard, there are 3 things which are really emerging that the people of Leeds consistently have told us that actually we need to think about in terms of improving health and care services. And we're describing those as the 3 C's. So that's communication. How do we communicate with people? Coordination, does care feel joined up? Is it easy to navigate? And the vital importance of compassion. So I just invite you to watch the video. It's not very long, it's 4 minutes. And actually, Adam and Emma have been sharing their experiences for a number of months now, and they have had serious challenges. They live in Wetherby, so actually they've had to, they've had to navigate receiving care from 2 different ICS systems. Emma's shared her experiences about being labelled with a particular diagnosis with her mental health. Emma's described her experience of trying to get assessed for autism, and also about her language. In one letter, Emma was described as this unfortunate woman. So there's been a number of experiences that we've seen through the videos with Adam and Emma, but this one I think is a really positive story, and I thought it would be really good to show in terms of how things are working in a positive way for Adam and Emma. Sorry, Manraj, I don't think the sound's working again.
This last month,
Oh, sorry. It is now, sorry.
I've been still going to my therapy sessions in under the Harrogate Health Integrated Health Team, or what they used to be, Community Mental Health Team. I've had my care coordination still, and have a big GP health check, like my review for my mental health, physical health, and medicines and stuff. And still been going to autism services. I had my Botox second Botox treatment, and we've also been going through a complaints procedure with Eskimo Valleys and Leeds and York Partnership Foundation Trust, and that's been really good actually. So the services and interactions and appointments that I've worked well this last month, I've been really pleased with where the therapy is going, because it's been doing something different to help with the voice, and when you're doing something different you've not tried, it feels hopeful because there's a chance that this one might work, rather than feeling like you're just going over and over and over. So I've been doing role play where I have to try and learn how to speak back to the voice, where the therapist is the voice, which I found really hard. Definitely different steps of improvement, and the voice seems to be getting less aggressive, which has been really positive. So I've got a pre-discharge meeting coming up, which means I might be discharged from services this summer, and I'm actually really excited. In the past, that's always been really scary and upsetting, because it's like, well, I've still got stuff that I still need help, but now it's like I know that I'll probably still need help every so often, or things won't always be easy. But more of the time things are better, and I'm given tools that I can manage better. How joined up services feel at the moment, I think it feels pretty, this is probably the best ever that it's been joined up, especially between Leeds and Harrogate, and between different services. And I think a lot of this is to do with my care coordinator. She's very, very good. I think it's contributed to how more positive I feel at the moment as well. Just, I think right now I feel like Harrogate knows exactly what I'm doing in Leeds, and everybody's involved, and so do Leeds. And I don't think that's ever happened before.
Your care coordinator is meeting with the kind of like your contact at specialist autism services to check in, and
yeah, they're having a meeting just between them two. I'm coming as well, but it's just so they can actually know what's happening in Leeds properly, and between the autism help and the mental health help, so they actually can tailor the support better. And that's just completely blown my mind. Nobody it's like that's really good.
Yeah.
One thing I valued most this month, the realisation that a lot of the professionals involved seem really truly invested in me, and invested in my recovery and me being happy and well, and being the best version of me that I can be. And it's just that realisation that professionals do seem to really care at the moment, and I've not always felt like that is the case.
Okay, Hannah, thank you. Yeah, I think you're on mute still, and if you were speaking, oh yeah, I'll hand back over to you.
Sorry, honestly. Yeah, it was only a short video. There is a second one where Adam talks about his experience as a carer, and I suppose just it's definitely worth watching because he talks about how actually it's so, you know, it's so much more positive for him now. Emma is receiving that care coordination, so he is not having to take the responsibility of that. So I would encourage you to watch that. But in this space, it's just to invite members to sort of reflect on what you've heard, and yeah, I'll just ask people to reflect.
Okay, thank you. I have Tim Riley with your hand up, so we'd like to come in.
Yeah, thank you, Emma, for sharing those videos. They're really good. It struck me, having been one of the people who's seen the earlier videos. I almost wonder if there's a fourth C. I'm not saying necessarily, but it's something about consistency, because their experiences this month have been reported in really positive, and that's great, and I'm delighted that they are, because I think that's the experience a lot of the time of many people encountering NHS and care and so on. But I do think we're not always as consistent as we need to be. This is something to me about consistency. The other piece, which I think is a really important question, is this one around coordination. And I'm still unclear in my own mind, and this is probably for a broader discussion at some point. What is coordination a necessary output of an overly complicated system, or is it just a really good thing? And I'm not totally sure I know the answer. I know it's necessary at the moment, but is it necessary because it's good, or is it necessary because we make the world so complicated you can't possibly manage it without coordination? So that's just a sort of thing that I'm chewing over in my head.
Okay, thank you. Good questions, Tim. Thank you for that. Hannah, did you have any insights into that? And while you're speaking, does anyone else wish to reflect on that video as well?
No, I don't think so. I mean, I think that the 3 C's as we're describing them, and they seem to resonate with people in terms of remembering them, but they're actually essential elements of the person-centred care model, and that is the way that all health and care services should be delivered, in that person-centred way. So you know, and I think particularly from our perspective, that the Quality and People's Voices Experience Committee have a really key role around ensuring delivery of that person-centred care model in the way that health and care services is delivered. But I think Tim's challenge around the coordination is a really good one. Many of the participants that we followed, and obviously it's based on more than just the videos, but you know, people just describe that they need someone to help because it's just so difficult to navigate. But whether or not there's something else as well as that, I'm not sure, and I think it would be good to explore.
Yeah, absolutely. Great. So I've got Sarah Monroe, and then I've got Kath to come in. So Sarah.
Yeah, it's just to add to that last comment, really, in terms of care coordination. So it is quite a well-defined role within mental health as part of the model of community mental health care, and has been for some time. So they don't just coordinate, they provide direct therapeutic input as well. And at the moment, whilst we've got CPA, fulfil the requirements of CPA, that is all changing in terms of the new model of community mental health and the transformation work that's taking place, with the absolute aim of simplifying it, Tim, because there are multiple front doors to access mental health services, each with different criteria, which means that often the negative of that is people get told multiple times, you've not come to the right service. So that's a different conversation, but that's where the transformation is focusing on, so that there is no front door and it's easy to get into services, and then making sure it's seamless and joined up as part of what the interventions actually look like.
Thanks, Sarah. I think it'd be really interesting for members who aren't in mental health world and this world all the time to understand that future a bit more. Certainly, I would like to. So if there's anything we can do to be educated on that and the changes that are coming in, I think we'd welcome that. Sarah, so if you could perhaps liaise with Sam about that, or someone else, that'd be great. Kath, would you like to come in?
Yes, it's always a delight to hear their journey, and that it's positive this time. But that point about cross-border collaboration, I can definitely say from things I get in my post box that it's not a smooth experience for quite a lot of people. And I'm just wondering, Hannah, whether or not Health Watch could do some insight work on people who live on the borders, because I've had examples where I think people have had their GP in one council area, but their bins are collected by a different authority, and then there is complete confusion about who delivers community health services, who's got qualifies around ordinary residents to do things, and actually it just keeps cropping up. And whether or not we need clearer protocols between agencies about who picks up what when. And whether or not we have some insight about people who are on the borders, what their actual experience is.
Yeah, and actually the work that we're doing at West Yorkshire as well, it might be interesting to do that as a West Yorkshire piece of work as well, across the 5 local places. So yeah, definitely happy to take that forward, Kath. And I suppose where we would start with that is what have people told us already, and then sort of go where the gaps are in terms of any engagement around that.
Okay, I think that's a really positive discussion and way forward, following that really interesting and very useful video. Thank you. I mean, the question I had when I was watching it was what was different this month to previous months, and what had changed, and was that down to staff, individual staff, or luck, or just better coordination in general? But okay, so I think we'll leave that item now and move on to the next item, which is also with you, Hannah. Item 6, which is to review and approve the ambition set out in the embedding involvement in the Leeds Committee. So this is about how we really do embed listening to people's voices throughout our committee work. I'm told that a discussion took place at the Shadow Committee, which you've all been working very hard on in shadow form on these arrangements, and that happened on the 17th of March. So work's been underway to consider how we will ensure people's voices are embedded in every level of the decision making and discussions that we have. So we've got 20 minutes for this agenda item. So if you can take about 10 minutes for an overview, and then we can have 10 minutes for feedback and questions. So I'll hand back over to Hannah and Kirsten.
Thanks, Rebecca. And I'm just going to do a short introduction and hand over to Kirsten. And much of this some committee members will have heard many times, but we have got new committee members, so I'll just talk through around this. The commitment around putting people's voices at the centre of health and care decision making has been a long-standing ambition for us within Leeds, particularly championed by the Health and Wellbeing Board. It's part of the Health and Wellbeing strategy that people should be at the centre, and set up by the Health and Wellbeing Board asked, I think it was 8 years ago actually, that a group be set up to lead this work, and that in the city is a group called the People's Voices Partnership. Now it was the People's Voices Group, but we've changed our name to People's Voices Partnership, and that group brings together all the involvement leads from across the health and care organisations within this partnership. So there's people from Sarah's team, people from Kath's team, people from Tim's team, all working together, and Julian's and all the partners here working together as one health and care listening team. We've done a lot of work over this past 4 or 5 years, really progressing that. And the idea is that ambition is integrated within each of those organisations themselves, but also as a health and care partnership. How do we do that together? So the work that we've done over the past few years has included things like the development of the Big Leeds Chat, the How Does It Feel For Me programme, but also we've got a forward plan and priorities around the way that we think we as a health and care system can really put people's voices at the centre of health and care decision making. And I suppose really just to stress, we as a partnership, we really believe that actually it's the voice of inequalities that really needs to be heard if we're to improve the health of the poorest fastest. We absolutely have to have those voices central to our decision making if we're going to make any changes around inequalities. So as Rebecca said, at the last Shadow Committee meeting, you were invited as committee members to consider this in 3 different ways. Firstly, how will you do that as a committee? So how will you ensure that people's voices are central to the work of the committee? As individual members, how will you model this? How will you link with communities? How will you hear that voice of the people of Leeds? And then as a health and care partnership, how will we do that? Since then, the People's Voices Partnership have been working on that, and actually much of I think from that meeting, it was brilliant because there was such a high level of ambition and commitment to this, and that is really exciting to work in a health and care system that has that level of ambition from its senior leadership around this. So as People's Voices Partnership, we've worked together to describe that. Alongside that, lots of work has been happening in the interim to make sure that people's voices are within some of the structures that you're going to hear about today, but things like the population boards. Kirsten and the team are doing lots of work around that, as well as different partners, including Forum Central, to make sure that the voice of the third sector and community is part of that, and the work that we do at Health Watch Leeds as well. So I'll hand over to Kirsten at this point to just talk you through this.
Okay, thanks, Hannah. I'm just going to share my slides. Just bear with me a second. I don't know if you can see that. Sam, can you see my slides?
Yep, we can, Kirsten. Thank you.
Thank you. So I'm just going to flick through actually, because I think this Hannah's pretty much just given a bit of an introduction into how this paper that we've shared fits into what we want to achieve as a People's Voices Partnership, and also and what we're wanting to sort of share with you today. So what we've just done is just distilled out from that some of the sort of key things that we wanted to highlight, and it's hopefully it's all fairly self-explanatory, but so we've divided it into the 3 different areas. So how do we want to start with people as a committee? And just to say, when we say starting with people, I think it's actually it's right that we talk about starting with people, but actually it's about us ensuring that we are listening to people and having people, as Hannah said, at every point in the decision-making process. So it's almost a cycle of decision-making and involving people, to have them at the beginning and to have them throughout the process, and then to communicate back to them how we've listened to them and how we've adjusted things. So I kind of very much see it as a cycle rather than just starting. It's the cycle, but that's what we mean when we say we're starting with people. And we've divided this into ambition, the current work that we're doing, the planned work, and what we need from the committee in order for us to do that. So as a committee, it's important, as we said, that we start with people, and that does reflect, as Hannah said, the People's Voices Partnership approach. We've been doing a lot of work around Involving You, which is hopefully a document that you've all seen, which is a summary of all of the involvement work that takes place across the city, in a coordinated way, and sometimes individual way, but that's a reporting mechanism that we have, Involving You, that we've been sharing with people, and we're really keen to develop that Involving You document and make it a regular working document that we can all refer to. And I suppose that for us, what we're looking for from the committee is that assurance that involvement is within every element of the committee. So if a paper is coming to you as committee members, we would hope that you're recognising that the person that's presenting that paper is talking about how they are going to involve people in the work that they're doing, if that's appropriate, and that you as a committee board are supporting the work we do around pulling those reports together on Involving You as well. We've put down, I'm not going to go through this in detail because we've not got lots of time, but we've pulled out the importance of demonstrating involvement in papers, that we are proactively feeding back to local people regularly. The planned work is to continue to work on that, to look at new ways of involving people. So for instance, like we might be setting up a committee blog. We are developing the new Health and Care Partnership website, and we want a section on there around this area. We've obviously been working on the team have been working for years on the Big Leeds Chat, and we're looking at how we continue with that, not necessarily doing a Big Leeds Chat every year, but certainly ensuring that we feed back and to people about what we heard and what we've done on the back of what we've heard in those Big Leeds Chat environments. Obviously, it's really important for us to be working with and involving diverse communities, particularly if we're going to be addressing the problems of inequalities. And so we are linking in already with various citywide groups, so with communities of interest, and through the digital subgroup, those sorts of committees. We obviously have a legal duty to ensure that we involve when we change our systems and our services. So it's about, we do that now, but we need to continue to do that. We've been doing quite a lot of work around with the population boards. As Hannah mentioned, we've been working really hard, looking at stakeholder mapping and making sure that we're involving as many people across the city who are already listening to people in the work that we do, and producing insight reports that have again been fed into by lots of different organisations for each of those population health boards. So we're doing lots of work in that area. The work around how we involve people is developing, and I know Sam and the team and Manraj are looking at how we involve people with Rebecca, just to make sure that that is happening, whether or not we are seeing people in public and we're inviting questions, and we need to look at how we can more proactively support the promotion of the agenda. And you know, we've talked, I know, about ensuring that we're holding the meetings in community venues and inviting speakers when that's appropriate. And as Hannah was saying, it's, I mean, we saw from the video at the beginning, it's really important for us to develop that. How does it feel for me, and to make sure that fits in with what we're talking about on those committee meeting agenda items. So that's the committee, and I think that's probably where I'm going to concentrate most of my work. I have also pulled in some additional information from the table, sorry, around how we as members would be modelling this, starting with people. And I suppose really the main thing there to highlight is that we would just invite you as board members to ensure that, you know, that you're listening to those, that you're going out and searching for the other videos that are on there. It takes a while to watch them. I watched them all recently, but they're really insightful and really inspiring to hear people's experiences. And to remind ourselves who we're here for. And also, I've mentioned the Big Leeds chat, but also getting involved in the allyship programme as individuals on the member, as members of the board. And then we've got a summary here, which I'll share afterwards, but it's of how we work as part of a wider system. And that is, as we were saying, lots of work that's going on around ensuring that we're coordinating and ensuring that we're listening to people across the city. And I'm not going to go into too much detail there because we're just going to summarise. But I think so just in summary, how can you help? So I think as a committee, ensuring that the committee papers have outlined plans to involve, getting involved in comms work to promote involvement and feedback to communities, inviting the sharing of people's stories at the beginning of each committee meetings, as we've discussed. I think it's really important that we really embed using plain English and avoiding jargons in our meetings. We've got lots of work to do in describing the complexity of the Leeds system, and I think there's a lot we need to do there to help people to understand how to navigate that system. Supporting the development of our Involving You document and the principles behind that, really, of sharing what we've learned and how it's made a difference to the decisions that we've made. Taking parts in things like I've just said about the Big Leeds chat and the allyship programme. Supporting the development of an involvement library, and that involvement library is about pulling together all the things that we know in one place, and ensuring that we as an involvement team, citywide involvement team, are sharing all the information that we have and doing what Hannah pointed out, which is that at every point when we need to learn something, we need to find out about an area, what do we already know about that area, and sharing the information that we have, and ensuring that our population health outcomes reflect the needs and preferences of local people. So I think those are the priorities, really. So really, we're asking today for you to review and approve what we've set out in the embedding involvement in committees documents, to put in place the things that we need to make sure those things happen. And we are looking at working together at a costed work plan for the autumn, which will outline sort of in a bit more detail how we're going to ensure that people's voices are embedded in decision making across the system. So I don't know if anybody's got any questions.
Okay, well, that's great. Thank you very much.
That was a lot. Chuck at you, sorry.
Thank you very much to both of you for that presentation and for the report. And must say that I think the spreadsheet detail is very welcome as well. Gives give some sort of good actions there. I'd really like people to put their hands up and say reflections on this and ideas, and then we can hopefully review and approve the ambitions and commit to do the work. But I just would like to also say, from my point of view, I think if we can involve people and give them influence, it helps our citizens to be empowered and have agency in their lives. And some of the most vulnerable people who use our services do need that. But we also need to use it as an innovation tool to make our services more efficient and do better integration. And I think having focus group style work, market research style work is really exciting potentially. So anything on that, any reflections on either of those or the whole report, very welcome. So I've got Yasmin first. Thank you.
Hannah and Kirsty, thank you. A really informative presentation and really useful document. Just to let everybody know, I've just come back from leave, so I know that some colleagues are going on leave and I'm just recovering. So I've read some of the reports and the information, and I think one of the really key things for me is, obviously I will be chairing the Inequalities Committee, is around diversity of voice, because I think it's really important for us to hear the different voices coming through, because I think that there's lots of work going on in different forums, but it may be that we miss a group. You know, if somebody, particularly with physical disabilities, we might miss that completely. Some of our Roma communities, we might miss those, and some of our South Asian communities, we might miss them because of some of the language barriers. It'd be really valuable for me to know in terms of, you know, some of the approaches taken for involvement for those communities. And just one other observation was around You Said We Did when I was reading the report. So there's lots of information on your website that's really useful. But what I found was it was really at the bottom of that page. So it didn't, because the positives of You Said We Did, it should really shine through. So it might be we can present that in a really in a powerful way, really, because, you know, it feels like we are listening to some of that feedback. That was just an observation.
So I'll step in and then I'll see if Hannah's got anything to add. I couldn't agree with you more, Yasmin, on the order of the way that we talk about that, because I really think that I always drum this into any teams I've had, is that benefits comes at the top of the page. So I completely agree that that definitely is something that we'll be looking at in terms of the way we put those pages together. I suppose one of the things to highlight is that it's really important for us as we're pulling so for instance, just as an example, as we're pulling our insight reports together at the moment, the key part of that work is to, as we're doing what Hannah said and looking at what we know about a particular area and a group of people, that we're ensuring that we're hearing from those various groups that are suffering from inequalities, and we'll be doing a gap analysis around who we've heard from and what areas that of information that we need, that we've got gaps in, and then there'll be a decision around how we go about filling those gaps. But I think you're absolutely right, and I think it will be really, really good for us to be pulling that together and pulling the gaps in. Sorry, Hannah, I've just seen that you've got your hand up there as well. That's just with the insight reports. That's just one example.
All right. Am I okay to come back, Rebecca? Is that all right?
Yeah, absolutely. Absolutely.
Yeah, I mean, just like Kirsten said, Yasmin, totally agree, and that's our fundamental, you know, our ambition is to hear that voice of inequalities. Traditional listening mechanisms don't hear that. Surveys you don't hear that voice. Friends and family, you don't hear that voice. And so we've really tried to turn it around as a People's Voices partnership. Say actually that's the priority. Those are the voices that we really need to hear, both within individual organisations, providers will be, you know, doing different things, but as a system, the principle of the Big Leagues chat was actually to go out to those communities. So we went out to food banks, we went out to the recent one with the Association of Blind Asians, meeting people in Roundhay Park as they were going for a walk. And that's our approaches are very much about going out to listen. There are no hard to reach groups. We have an amazing third sector organisation and community organisations that we can link into. There is no excuse to not hear those voices. We can partner up and we can hear them. And I suppose just building on that, you said it's actually about co-leadership. The people of Leeds need to be co-leading this with us, and particularly the voice of inequalities need to be co-leading with us. And part of that is the importance of feedback, because people often say, we keep telling you what the issue, you keep asking us, or you keep telling us. So actually we really need to demonstrate, and as a People's Voices partnership, we've made feeding back one of our priorities as a partnership. We all need to get better at that. We at Healthwatch need to get better at that. It absolutely, because then people will have trust and think actually their voice matters. So and there was just one other thing I was going to say as well, just around what we already know as well. Just like Kirsten said, another PVP principle is we don't need to keep asking people the same questions. We did a piece of work during COVID at Healthwatch where we were going to go out to different communities and say, how is it for you? And John Beach at Lassen, the Refugee and Asylum Seeker Support Organisation, said, Hannah, actually, we know what the issues are. People have been telling us consistently around what those are. And from that, we did a series of interviews and conversations with groups that work with people with the greatest health inequalities. And they identified 10 key things that health and care organisations can do differently to better meet people's needs. So I suppose the other plea from us as a People's Voices partnership, and we took that to the Health and Wellbeing Board, it's one thing to be a listening city, it's another to act on what people have said. So that really sort of demonstrates the importance of the insight reports that Kirsten and her team are pulling together. I suppose our challenge to the health and care system is to make informed decisions. You really need to understand and hear that voice of inequalities to enable you to take decisions. And I suppose, just sorry, Rebecca, my final bit is I think in terms of the structures with the new Leeds Committee, Kirsten and the team are doing lots of work and other partners around the population boards. We've been influenced about the quality and people's experience, but I'm not so sure about the delivery and the finance committee. Again, my challenge back would be, how are you making sure that people's voice is essential to those committees as well?
Okay, I appreciate.
Can I just make one other point as well?
Okay.
Sorry, just
Kirsten, we've got 3 other people who want to ask questions.
Oh,
so
sorry.
maybe we could I'll get those questions asked, and then we'll come back to both of you for a bit of a roundup, if that's okay. Otherwise, we are going to run quite over, and I don't want to eat into the break. So I'm going to go to Victoria first, if that's okay. Victoria Eaton.
Thank you, Rebecca. I'll be quick. So just a comment, and then just some thinking maybe about a challenge for us as a system. So I do remember the workshops back in March. It feels really strong in terms of I remember the conversations back in March being about meaningful engagement and trying to make it as meaningful as possible in terms of our approach. That feels really positive. So thank you, Hannah and Kirsten, particularly around those underrepresented groups. So absolutely support the sort of relentless focus on that work. I think the mechanisms that we have as a city are so incredibly positive, including all the Involving You architecture, Big Leeds Chat, and the Voices group. So such an asset for us to have that and to use it really well. The challenge for me is particularly around how we maximise our opportunities for working across into other kind of systems to reach particularly those people who are underrepresented, because this is predominantly based around the health and care system, and I know there is lots of work going on, but potentially we could do more about going into, for example, local authority, local democratic systems, community housing residents groups, local community leaders, etc. And I'm not sure there's as much in there as we could stretch it to really reach people. So I think that's my only comment really about how we continue to build that. So it's not just a health and care process, but it's a city process. Thanks, Chair.
Thank you very much, Victoria, and very well, points well made. Jo, I'll bring Jo Harding in next, and then Tim.
Yeah, thank you. It's a bit of an extension, I think, of what Victoria's just said, and Hannah. I think, what I think I'm sensing is that through involvement, we really need to try and better understand people's lived experience, because the value that we can get of understanding somebody's journey, as we've heard with some of the videos, to press, but also an opportunity for us to not shy away from exploring some of those perhaps more unpalatable journeys that individuals are experiencing, particularly around our safeguarding processes. And the Local Adult Safeguarding Board has done some significant work working with individuals who've lived through our safeguarding processes and trying to understand how they may have impacted on that individual's adverse life events, etc. So it was just to make sure that we're connected, the People's Voices Partnership are connected also with insights in how people feel they have been or have not been safeguarded by our system, particularly in relation to exposure to domestic abuse and other things. So it was just a plea really for us to make those connections.
Okay, thank you. And I'm assuming at our subcommittee, Joe, as well, at People's Experiences, we'll look at that sort of work routinely and in a committed way there. Tim, would you like to come in, and then I'll bring Hannah and Kirsten back in.
Yeah, thank you, Rebecca, and thank you, Kirsten and Hannah. Really good to see the document. I think three things I suppose I would just almost like to emphasise, or us to emphasise. One, there's something about having an ambition that we're really systematic about doing this. I think we've got pockets of excellence, and I'd like to see us be ambitious about excellence everywhere in terms of how we involve and people. The second thing, which I think, well, it is there, I wonder if it just needs to be stronger, is that sense of co-production and the importance of lived experience in the moment and in the time when people are working on things. There's something about insights coming in, but there's nothing better, I don't think, in terms of relational matters, of having that voice challenging you as you are doing work sometimes, and that diversity of voice, absolutely, but are we strong enough on co-production? And then the third one, and it links back to the 3 C's that we spoke about earlier in terms of compassion and so on. How we test it's made a real difference. So are we improving communication? Are we? I'm not sure I know the answer yet. Are we making the world more complicated and therefore communication and coordination are getting more difficult? I think we need to be really tough on ourselves about demonstrably, for lots of people, making things better, and hearing that back. So that they're extra challenges. It's there, but I think we should be really ambitious about those things.
Okay, can I ask Hannah and Kirsten just to take 1 or 2 minutes to answer those questions and sum up? That's very difficult to do, I'm sure, but it's one of those items we could talk about all day. It's so important. So yes, thank you for that. Go on.
Yeah, shall I just kick off, Kirsten, and then
go for it.
Finish off? Just really welcome the comments and the leads around particular areas. Victoria, on the listening as a city, I think that would be great, because that's what people want. They want to know that we're listening as a city, not in little bits of their lives. And how we do that, it's challenging enough to do it as a health and care community, never mind with everybody else, but it totally is part of how we need to work, and it'd be great to do that. The safeguarding, definitely happy to link that in. And then your challenges there, or I totally agree around systematically, how do we do that? And actually, I was just on a call at West Yorkshire, and they're really ambitious around this as well. So and then there's a new paper as well that's come out on guidance around involving people and communities. So actually, we want to do it anyway in Leeds, but I think there's an ask from lots of different drivers around doing this. And there was your last point, Tim, which I thought was really, how do we measure around the 3 C's? Those are the conversations that we've been trying to influence around the population outcomes and the measures on each of the population boards. Can we measure those 3 C's for each of the population boards as part of their measures? And then how does that relate to the quality? How does that relate to the Quality and People's Experience Committee? Are we measuring? Is that one way that we're going to assess quality? So yeah, it'd be great to do that. These are just conversations we're having, but your thoughts and input into that would be great.
So I've probably only got a couple of things, just really quick things out there, because I'm really mindful we're over time. So so one is, and I think it answers a few of the questions as well, actually, and probably particularly Tim's around co-production, is that it's really important that we nail, and we're working really closely with the population health boards to ensure that in each of the different areas we are keying in, and we've got that stakeholder mapping piece of work done really well, so that we are listening to community groups and organisations that are already out there and that already have information, and so that we're making sure that there aren't those gaps. I think that's, and we are, as we work through just the insight reports as an example, we are speaking to them, feeding back to them, saying this is what we are hearing, is this everything, have we missed anything, should we be speaking to anybody else? So I think that continual conversation to make sure that we are listening and hearing, and Yasmin, I think it also answers to your question as well, will be really key to the work that to the work that we do. And the other thing is, as well as around the robustness of the work that we're doing, and ensuring that we are being almost as scientific as we can, and adhering to certain principles around sort of insight collection, and that we're using those principles and sharing with partners is really, really important. I think there's work that we need to do there. But I think as a PVP, we're really committed to doing that. So.
Thank you very much. And that's a really important piece of work that is, I'm sure, going to be exciting working on with you going forward. So thank you for bringing that to us. Can we, as a committee, approve the ambitions and commit to the actions that we are collectively signing up to within this report? I'm assuming, Sam, you don't need people to put their hands up. We can just take silence as an approval.
Yeah, that's fine.
Yeah,
Thanks, Rebecca.
Thank you. And just to say that we've received the costed work plan as well, just to note that. Thank you very much. Thank you, everyone. Thanks for coming, Kirsten and Hannah as well. Thank you. Got some thumbs up coming out, so people are happy with that. Well done. Thank you. Okay, so we're going to go through the next two items, which are the item 7, which is the Leeds Committee of the Integrated Care Board Terms of Reference. So that is our board. This is what our committee that we're sitting on right now. The Terms of Reference, this is for noting because they've been reviewed and approved by the ICB board as well. So just to note that item 7. Are we happy with that? Okay. Right, so item 8 is the subcommittee terms of reference. So these are to approve. So they are attached. There are 3 subcommittees which have been raised already today, been developed over the last 6 months. We're just asked to note there have been minor amendments since the previous iteration that was presented to the Shadow Committee, I'm assuming last meeting that you all met. They'll be continually reviewed as the subcommittees develop, and any major changes would return to our committee, the full committee here, for approval. Any questions? I believe they're going to be directed to Sam, if there's any questions on those terms of reference. Brian.
Yeah, sorry, it might be pedantry, but in the membership, some members are listed as when required and when relevant. And I wondered how that counts for chloracy.
Thanks, Brian. Are you particularly talking about the finance subcommittee there, Brian?
Yes, that's just one I'm looking at the moment.
Yeah. So we'd had a conversation with Visa, and rather than having all of the DOFs at each finance committee, it was a conversation that it would be dependent upon the agenda items that were there. I don't know if Visa, you want to add anything further, but and again, Brian, I think it's really important that whilst we're at each subcommittee, we're reviewing that and that membership, and we can then take it forward into the next meeting. I'll let Visa.
Sorry, Sam, that wasn't the question. It's like, for example, the Director of Population Health is when relevant, and chloracy is 50% of the membership. So is chloracy including the person who only attends when relevant, or not including that?
Okay, yeah, thank you, Brian. Yeah, I'll go away and just double check that. But yeah, again, with the Director of Population Health Planning and Director of Pathway Integration, the conversation we'd had was, again, it would be dependent upon the agenda item and which was the most appropriate director to attend to provide the detail on that. But yeah, I take your point and I'll look at the quoracy for that. Thank you.
Thanks, that's helpful. And we'll get that back to you on the rest of the committee as well for clarity. Thank you, John. Next, you have your hand up.
Yes, thank you, Chair. Yeah, we've already decided that it's very, very important to put the voice of the people at the centre of all our discussions, and that we start meetings with looking at the voice of the people. I assume that will work its way through the 3 committees as well, and that they will adhere to the same philosophy. So we just need to work out how that will actually work out for each of those committees.
Okay, Tim, is your point on that, or is it a different point?
Yes, I mean, it's to agree. I think it would be, given things like the Finance Committee, for example, maybe looking at significant business cases going forward, you would have to make sure that the public were involved in the discussion and the design of whatever the service model that was pertaining to. And similarly, the Delivery and Health Inequalities group, yes, I mean, it has to be part of that because they'll be looking at the delivery of those outcomes for populations. So yes, we may want to strengthen that, I'm sure, going forward and note it in some written words. But I think the principle 100%.
Thank you.
Okay, and I suppose the bit about the terms of reference can be reviewed as the subcommittees develop. We can add that in, I guess, another time. Joe, I've got Joe, and then I think that's it for comments on this. So Joe, would you like to comment?
Yeah, thank you. John's point in terms of the Equality and People's Experience Committee, I was having the same thoughts as we were going through the last presentation. I think the role of the Equality and Patients Experience Committee is largely around assurance. So it's important that in every conversation we are having, we are making sure that the patient and the user is central to the quality issue or the improvement that we're looking for in the conversations that we're having. So we just need to get very practiced at that and hold the population boards and other boards to account in making sure that people are central to the delivery of high quality safe care.
So I'm hearing then that there's an assurance function rather than necessarily as much a doing function in terms of commissioning things. So we need to be assured that people have been involved at all levels.
I think that's where the conversation, that's where the conversation's taken us so far. But as you quite rightly said, as the committees develop, we can make sure that we're checking and we're remaining curious about that and change it if necessary.
Thank you very much. Thanks, John, for that comment. So with that, are we happy to approve the terms of reference for the subcommittees? I'm getting nods and I haven't got any hands raised, so I'm going to take that as an approval and some thumbs up. Thank you very much. So we're going to go to item 9, which is the place lead update. So Tim, you are our place leader. This is your first formal update to the committee, so take it away and then we'll have questions for you and comments, I'm sure. Thank you.
Thanks, Rebecca. I'm going to touch on 4 things. Something just noting around the ICB formally coming into existence, so that's noted as we're a subcommittee. Something around the current existing system pressures, and then to mention an update to some members who will have heard of this before, the sort of Leeds proposition prospectus and where that's up to and its development. And then I want to just touch on Leeds is an NHS England place pilot. And I think it's quite important that we're just reminded of that, and I'll make a proposal about bringing something back to the committee in due course. So in terms of members, obviously will be aware that West Yorkshire ICB came into was formally inaugurated on the 1st of July. I think it's important that we note that in our minutes. The first board meeting was held on that morning of the 1st of July. Sarah, Julie and myself, I'm sure there are others, were involved in that. It was by necessity and mainly governance. So it was all about necessary appointments, and those were made, policies being agreed, terms of reference, for example, our committee, which we've just noted, and the scheme of delegation was also approved. In approving the terms of reference for the Leeds Committee, the ICB, and the necessary delegation of powers to us as a committee. So those have all been approved as of the 1st of July, and that means the ICB is inaugurated, but importantly, so is this committee as one of those committees of that board. I probably should just mention, since the meeting, the following people have also been appointed as independent members. So there were 2 independent members anyway, which we've noted in previous meetings, but 2 additional ones. So Majid Hussain, who was the former chair of Oldham CCG, has been appointed, and Professor Arasungosu Chatterjee, who's the Professor of Digital Health and Education at Leeds School of Medicine. So those are the 2 additional independent members appointed to the ICB board. And I think it's now looking a really strong board in terms of membership, so that's excellent. So secondly, just to quickly cover the situation in Leeds, people will be aware, because you'll have picked it up probably nationally if you've not already picked it up locally, that COVID is back, and that has put considerable pressure on our system. I think aligned to other things, in all honesty, not just COVID, and also the heat. We got a heat warning, particularly into the back end of this weekend and early next week, where we're expecting really high temperatures across most of England and West Yorkshire as well. That resulted in us having to declare a level 4 incident in Leeds, which is the highest level. We've not really declared that before, but the position of the hospital reached that point, sort of particularly over the back end of last week and over the weekend. We have stepped that back down a level today, but nevertheless, it remains really, really difficult and very, very challenging. There are 212 people as of yesterday in hospital beds with COVID. And that's probably the highest level it's been for a good number of months. So this is not, whilst they're not necessarily being admitted for it, they're certainly being admitted with it, and that's putting pressure on the system. In terms of immediate action, we've stood up silver and gold commands as we need that. And there are a number of pieces of work being overseen, which I won't go into the detail unless people ask, and then other colleagues will perhaps be able to update. But that, I think it's important for you as a board or a committee of the board to know that we have instigated that level of engagement with the situation. It's important as well that you understand there is then an ongoing sort of transformation programme of work in place with a programme director. That's got 3 phases. Phase 1, sort of first 90 days, which we're now in, doing all that we can to improve the position fairly quickly ahead of the onset of autumn and winter. And there are a number of pieces of work that sit within that, things around transfer of care hub, bed brokerage, etc. We've also got that overall programme has then got a second phase, which is more around intermediate tier and building additional community capacity. That will take us a little bit longer, but should start to certainly have some effect throughout the coming winter, albeit perhaps not to the full degree that we will want, but nevertheless it is underway. These are not concurrent phases. They are concurrent phases. They're running together. And then the third phase, which is probably a more fundamental reform and will clearly take longer. Importantly, that programme of work is there are no quick solutions to some of this. We are making the changes that we need to make where we can, as fast as we can. But importantly, there are changes we need to make, not just in terms of process, although that is important, but in terms of capacity and where that capacity sits, particularly out of hospital. And then thirdly, in terms of the culture of the system, a home first, a risk-based approach and so on. So there's quite fundamental changes that we need to make. So that situation in Leeds is challenging. 2 other things then to cover briefly. One is just around this Leeds proposition and principle and prospectus. We felt it was important that we had that, and we had something written, documented, that was fairly simple, that was clear, that pulled together an enormous amount of work that we do as a city, some of which you'll have heard about today and in previous meetings, which is enormous because Leeds is a big place, but to try and make that clearer. And that's for 2 reasons. One is external, to put ourselves in a good place, if you like, to pitch Leeds as a place to come and work with if you're working particularly with NHS England and want to develop that sense of place. But also internally, in terms of communicating our ambitions, the health and care partnership, and what it will contain is something about the why and the rationale, which we will rehearse and have rehearsed many times. What is our ambition for, say, the next 5 years in some key areas, and then really importantly, what are the assets we're building on, and what are the other building blocks that we think we need to put in place. The proposal is that we'll start to share that really widely, including with members of this committee fairly quickly in the next few weeks, and then probably return to that in terms of a public meeting the next time we meet in public, having done some more work as a partnership in terms of just tightening that up and refining it and so on, and making sure it's shared widely. It's meant to be used. and I was having a conversation with colleagues today about quality improvement, and I was using some of the reflection and so on as almost a bit of a mandate to help steer that work, and we will be using it, and I'll be sharing it with chairs and so on next week. So I just wanted to update you where that was up to, and that would be coming through. And then finally, we are working closely. NHS England asked a number of places within each ICS, not every ICS stood forward, and not every place in every ICS wanted to be involved, but Leeds is one of the places in England that is being working with colleagues from NHS England and others to develop and see what a really good place looks like within an ICS partnership. That means quite a lot of hard work is going on with colleagues across the city, and also quite a lot of input and expertise is also coming into the city to help have those conversations and shape that. I think it'd be really helpful if we had a brief, perhaps for the next time we meet, just to understand where that's up to, what's going on, and some of the really exciting work that's coming out of that about how we use data to identify various things. One excellent piece of work is our long-term conditions board, and is working quite closely with the mental health board to identify those people in the most deprived parts of Leeds with 3 or more long-term conditions and a mental health condition. And that links very strongly to our desire and our ambition to improve the lives of people with mental health, and that parity of esteem in terms of their physical health and well-being. So a really key piece of work, and it's that kind of thing I think we ought to showcase, because it's so often happening and we don't see it. So I'll be proposing that we do bring back something from that work, but I just wanted to flag it is going on. A lot of our colleagues are actively involved, as are the population boards, data teams, finance colleagues and so on. So I'll stop there, Rebecca.
Thank you very much. I'm wondering whether we would, can see John's got a question, but whether it might be useful to go straight into the 5 minutes on the healthcare inequalities funding, and then just take 5 minutes after that to ask you questions, if that's right with John, unless it's completely different to that, John.
Well, if I could just ask, it's quite a quick question. Tim mentioned that on the 1st of July, the West Yorkshire Board approved their scheme of delegation, what services they're going to delegate. And it is actually mentioned in their papers that as Appendix 1 to something, but that Appendix 1 wasn't there. That's fine. But I just think that it would be useful for us to know what has been delegated to us.
Okay, go for it.
I'll ask Sam to circulate that again. Is that all right with the minutes, Sam, so that everyone can see the full
Sam's
scheme?
put a hand up, so I'm assuming she could.
Yeah, I can circulate it again, and the link should have been under item 1, John, where it took you to the governance handbook, which basically had that entire paper that was presented to the ICB board. But I'll pick out that specific scheme of delegation and circulate that as an individual item.
Thanks, Sam.
Okay, can I then ask if it's all right with the committee for Tim to go into the 5 minutes on healthcare inequalities funding, and then we'll have 5 minutes or so before our break, just to raise any questions on both of those items, if that's all right. Okay.
Okay, so it's the health inequalities funding then. Colleagues will be aware of this because we've discussed it in previous meetings. A decision had to be made before we were inaugurated on the 1st of July, and that decision was delegated to me on the basis of this paper, which was then has already been circulated previously to that. So this is for ratification. I think it is important to notice that the money came through with a particular NHS England focus, which isn't wildly out with what we want to do, not at all in terms of health inequalities, but it is important that caveat is there. It was again a short time frame, which isn't always the most helpful. I do think it's really important to notice within the report that there was a sense of a lot of engagement in that short space of time, and that what we brought through were schemes that either were already in existence and perhaps were threatened, or where we weren't quite sure where the funding was coming from, or that had been in the pipeline for some time. So what we didn't do is just start to create a whole set of new work, although it can feel like that. I think it is important, given the timeframes, that whilst it was really engaging, there was a sense of learning from this, that the population boards are still maturing, and that if we were to go through something like this again, there would probably be a much stronger sense of these are the 3 or 4 big things that we need to do that perhaps we didn't quite have at this stage. I think final thing probably just to note is that what was really positive about this was that there were a lot of integrated bids, people working together. This wasn't a piece of work. But when I say bids, I'm annoyed at myself for using that word, really. This wasn't a set of bids competing with each other. This was much more a sense of already identified work being done through joint mechanisms where people were taking on that responsibility to work together to identify and deliver the best set of things. So it is an important step, although we recognise there will need more to be done. I'm not going to say more than that because I think the paper is quite comprehensive, and I know we covered it in a lot more detail when we met in shadow form. Those of us that were here in June, I think. Was it May? Lose track. May, probably.
Okay, thanks, Tim. So none of this is a surprise to members who've been involved for some time, which is what I'm assured of. It is good to see collaboration happen rather than competition, because that's the whole point of these new legal arrangements, that we can get away from the presumption that competition will happen, but actually if we all put our heads together and decide what we want to do together, that's probably better value for money in the long run. And it is also very good from my point of view to see the list of proposed projects and projects that we're approving, small pots of funding, community-based, very targeted, infant feeding, that sort of thing. So from my point of view, it looks good. But can I ask members to indicate if they'd like to speak? And I've got Yasmin first. Thank you.
Tim, thanks for the overview. Just a couple of points from me. I think, firstly, that I agree, Rebecca, really great to see the collaboration. And for me, obviously, with the background in BCS, that 37% of the funding is going to BCS organisations, grassroots, really understanding the communities. I think that's fantastic news. And the integration, I really value that. I just wanted to check around. I agree with Tim also that obviously with timing, it would be really useful the next cycle to look at top 3 or 4 priorities, to have it really focused in terms of, investing our money. I've just noticed, Tim, on the report that there were, I don't know, it might just be my, lack of some of the knowledge for some of the organisations, but for some of that funding, I think what I picked up that there was only potentially just one BCS organisation delivering some of those, organisation delivering some of the key services. So, for example, I picked up for Young Black Lives Peer Support Group, and I think Leeds Minds is a fantastic organisation and really value them, but I'm not sure that, are they the right organisation to deliver that element of the work? That just kind of putting that question out, or does that need to be very much focused for an organisation with that niche group? And I think there was one other point I wrote. And the only other aspect for me was around how do we, so those are great, we've allocated that money, and then in terms of obviously being new again, it'd be really useful to hear how we will measure the impact of that spend for us over the next that spending period. Thanks, Tim.
Tim, I'll take 2 more points, and then if you can come back to them all, that would be great. Thank you, Yasmin, for that. Julian, I've got you, and then I've got Francesca. Thank you.
Thanks very much, Rebecca. I didn't want us to lose Tim's key point about pressures right now, because we meet as a board in what is probably the most challenging operational period we've experienced, in the sense that, as Tim said, we've escalated to Opal level 4. And as a system, we work together to tackle those challenges, but we can't be under any illusions about the scale and scope of those challenges in relation to what that means, obviously, for our patients and our citizens. And that's been articulated through the previous focus on how it feels for people. But certainly we face a combination of enormous pressures in relation to the number of patients and rising with COVID. And today, Tim, I think we're up to over 220 patients with COVID in the hospital. That, of course, has a huge knock-on impact given the community rates on workforce across all of health and care services. And all of us are feeling the pressure in relation to our sickness absence rates with COVID across that. And then, of course, the number of patients in hospital that really don't need to be in hospital. And we have a home first philosophy in Leeds, which is crucial. But we are the biggest in the NHS in terms of the number of patients in hospital with no reason to reside. We've also got an enormous challenge in relation to elective recovery and backlogs. So you take all that together, Rebecca, and I think as a place board, the challenges we're facing are, you know, we can't underestimate them. And I think Tim's report is important in the sense of acknowledging that and working with the public to tackle those issues and working as a system in a joined up way. And we've got plenty of work going on in that. And I'm sure you'll want to bring back reports on those key items to future place boards to track how we're doing and how we're tackling those real issues and challenges across not just acute services, but community services, social care, mental health, and across all of our communities as we head into what I think will be a challenging autumn and winter. One thing I would say, though, is where we are doing well is in relation to the nationally prominent issue of ambulance handovers. So the danger of patients waiting too long in the backs of ambulances before they're moved into the emergency department is an issue that we perform well on in Leeds and continue to do so, working with Yorkshire Ambulance Service. So that's something I think where we demonstrate we're putting the safety of patients first and ensuring that we can do what we can under huge pressures. So thanks for that.
Thanks, Julian. I think we could, is such a big subject and one we have discussed as a system many times over the years and done a huge amount of work on. So I'm completely with you on the importance of it. And actually yesterday we added to the forward work plan that we should bring winter planning in September if possible. And I was going to raise that later, but precisely because we want to make sure we're talking about what's happening right now in terms of, you know, that's happening in our system, the pressures we've got, not just things we'd like to do and the funding we've got. However, I don't think we can cover it right now because I don't think we'd have the time to really go into the depth of it, which is what it requires. But we should definitely be bringing those sorts of items and that in more depth. I'm just going to bring in Francesca and then Chris Mills and then bring Tim back so we can have a break and I'll try and add 5 minutes on. Okay, thank you. Oh, Francesca, please.
Thanks. So thanks, Tim, for the update. And I just wanted to build on Yasmin's point very briefly. Forum Central was very much involved in the Health Inequalities Fund work, and it was such a fantastic opportunity to actually collaborate and really make sure we were all round the table from day one on developing and working through how we were going to use that resource. It was also a way for us to almost accelerate some of the work that's going on through the population and care boards in helping people think differently and work together much more than they have before. So I just want to thank all colleagues involved in that because that was a really positive process. It was very hard work in a very short period of time, as Tim had mentioned, but it was a really productive process and I think it's led to brilliant results. Part of that is also about how much health inequalities is about the wider determinants of health. So it's a real opportunity for other colleagues and partners sitting around the table to understand what else third sector organisations do that support the longer term health and well-being and those wider determinants of health, particularly with underrepresented groups and areas of deprivation. So a fantastic building block for us to move that work on with. Thanks.
Thank you, Francesca. That's a really good comment. Thank you for that. And Chris Mills, Yasmin, is your hand up because of early question, or have you got another point? Ah, okay. Chris, and then if we can bring Tim in, great.
Okay. Hopefully you can hear me all right without too much background noise. But I just wanted to echo Julian's concern. And I know the board's remit is very broad. But I just wondered where we felt our biggest problems were. And I think if you look at the knock-on impact of Opal Falls at this time of year, and then looking at extending that through cancelled operations, I can't think of much else in our system that's going to cause so much trouble. So my first question is, have we got enough resource aimed at tackling this problem? Are the relationships in the right position? And it's great to hear that we're putting ourselves forward for all sorts of things nationally to be pilots for things, but are those things that are additive to our push for our very real problems, or are they things that are going to take resource away from what should be rightly our number one pressure? Thank you.
Great, thanks very much for that. Good points, very well made. Tim, would you like to come back on all of that? Thank you.
Yes, certainly. I'll try and come back fairly quickly. In terms of Yasmin's points, we'll certainly go away and reflect on some of those and feed those back into future processes, because I think they're really important. In terms of evaluation, there is a fairly rigorous set of metrics that underpin all the bids going forward, and we will come back and bring that back in December. I think it's on the forward plan, if I noticed correctly. An update of where we've got to and so on. So we will be evaluating those. I think it's so then in terms of Chris and Julian's points, really, I think it is good that we bring something back in September and have a considerable look at this. What I'd hesitate to call is winter planning. I think winter planning has a certain set of connotations in the NHS. I think this is more a sort of robust review of where we are, yes, going into winter, but where we are, what the pressures and the risks that we face, what the action that we're taking in is underway anyway, and then what further escalation we might need to put in place. The danger of the winter planning, in very purist sense, giving it that title, is it's the escalation for a few months, and I think this is more fundamental than that. In terms of, we've got a lot of resource on it. I guess my concern and why I'd almost like to bring this alongside the work we're doing with NHS England is the danger of having something that's important and urgent sat alongside the something that is important but not urgent. Is that second is what you end up with is you never focus on what's really important in terms of, for example, the management of long-term conditions. If we look at some of our pressures currently in the system now, which are extreme, my argument will be in part is that we never got to grips with the management of long-term conditions early enough, and therefore and addressing health inequalities. And what we see then play out is extreme pressure on our acute end of the system, and on social care. And we have to do both. We absolutely have to do both. We have to be the place that manages both those. So yes, we're constantly reviewing the amount of resource, and we've put additional resource in. Relationships are tough. They are good. They are good, but they're not without challenge, undoubtedly. In answer to Chris's question. What I would hate us to do is to become a place only obsessed by the immediate situation. We need to maintain that long-term perspective as well. So I think we're doing well in balancing those two things, and I think it would be really helpful if at our meeting in September our agenda reflected that important balance. And we gave some really focused time to what is, as Chris and Julian and I would say, is our most pressing immediate concern, to that longer and what are we doing in the medium to long term to make sure that we are not constantly in this kind of position as we go forward.
Okay, thank you, Tim. Now, if we can ratify the decision that the accountable officer took on the approval of the health inequalities funding, so we're agreeing the recommendations in the report. After the break, we're looking at the financial plan submission, and we're also later on looking at a letter of support that will hopefully address some of the present issues in backlogs if we are approving that later on. So there are items on the agenda looking at those issues in the round. Is that okay? Can we approve the recommendations and go for a break? I'm not seeing any hands up, so we'll thank you. We'll take that as a yes. So can we come back at in 10 minutes? So 48 minutes past 3, if that's all right. Okay, if you can turn off your microphone and your camera, and see you back in 10 minutes. Thank you. Okay, thank you very much everyone for returning promptly, and hope you've had a nice break away from the screen. So we're now going into item 11, which is the Leeds Financial Plan submission for 22-23. So I'm told again, due to timescales, and given the CCG was still at the statutory organisation when the plan submission was made, this plan is being brought to this committee for ratification. I think that's just the way that it is in terms of the changeover of the legal framework surrounding the organisation. So if we can have 5 minutes overview of the paper and just 5 minutes for discussion. Sorry, these are such tight timescales. It's just how it is today. I've got a big packed agenda. So if I can hand over to Visa, and is there anyone else you want to bring into this item, Visa? No.
No,
okay,
I've got. Yeah, I was going to say Brian's here, so he'll correct me.
Okay, if you could just take 5 minutes, and then we can have a discussion. But go for it.
Brilliant, thank you. So this is very much around the budget that's delegated to us from the ICB. So in answer to your question, John, it is basically the 1.4 billion pounds that we used to spend as a CCG. That's now been, well, it's actually 1.5 now. It's actually been delegated down to this committee to manage what used to be the CCG's budget. Because the transfer to the CCG, from CCG to ICB, fell mid-year, very, very confusing. We ended up submitting a plan as a CCG for a whole year, and then the planning process was updated and updated and updated. So we had one submission at the end of April that the CCG governing body approved, but we had to do another set of submissions because overall the NHS received further allocations of resources to support us with inflation that we didn't know about last November when our budget was originally set. Therefore we submitted another plan on the 20th of June. As a system, we submitted a balanced plan. We're talking only about CCG resources, so the risk around this plan is around £18.5 million worth of efficiencies that we have to find in order to stay balanced. That doesn't cover the risk that exists in the other NHS organisations, such as LCH, which has a risk of around £10 million, LYPFT around £6 million, and Leeds Teaching Hospitals around £84 million, and that's after quite a significant cost improvement plan. So all of those are separate. Also, similar sort of size risks of about £17 million at the council. And also on top of that, there's risk with inherent in all our providers, all 300 odd contracts that we hold with our providers. All of those providers are also experiencing inflationary pressures, which are unprecedented. So it is bleak, and I know people always say, you finance people always tell us at the start of the year it's bleak, but I think this year it's difficult because we have the double whammy of having COVID levels still very high and the costs associated with that, and the fact that we're trying to recover and to treat as many people who are on the backlog of the of treatment register. And therefore, yeah, we've got quite a lot of risk and cost pressures in the system. I wasn't going to go into huge detail unless people have any questions on it, but what I'm asking is for people to note the financial plan, the fact that we've had to make some changes between the April and the 20th of June plan. Note the risks that are in the system. I've given you a sense of the wider risks as well, and to ratify the submission so that we can set budgets both for Q1 and for the rest of the year. I guess the last question then is, what's the assurance process you'd like to see in terms of financial reporting going forward? So I'll stop talking.
Okay, thanks. Good. I was going to see if Shell wanted to come in. You're chairing the Audit Finance Subcommittee, so please go ahead.
Thank you. Yes, I've read the report and it's good to see the position has improved slightly from the last meeting when we were in shadow form. But I guess from an assurance perspective, my view is that it will be the role of the Finance and Best Value Committee to really go into more detail and constructively challenge in order to provide the assurance I think that we will need. And I guess I'd flagged up a couple of questions in terms of this particular report, in terms of the plan. Visa's answered some of that really helpfully, so I think we understand the wider system pressure, which just doing a quick adding up, that comes to around 100 million additional pressure. And then there is also the risk of the ESR funding, which is reliant on a West Yorkshire wide delivery of the additional targets. And just to clarify the figure that relates to, the additional risk, if you like, and I apologise, my cat's meowing. Is that 27 million, Visa?
Sorry, say that again, because I've just lost connection.
Sorry, it's the ESR funding potential loss.
Yeah, so the elective recovery funds, so that is the at Leeds Teaching Hospital is incurring the costs, but they will not earn the money for treating the backlog of patients if they don't hit a certain threshold, which is around 104% of what was the activity in 1920. That's about £45 million for the year. And at the moment, they are not hitting the full. It is a progressive target, but they're definitely not anywhere near the level of full earning of the money. So the risk is up to £45 million. Yeah.
Okay, thank you. And I guess the latest position in terms of increased COVID cases in hospital will increase that risk, I guess, certainly immediately. And my view would be that at the Finance and Best Value Committee, we will scrutinise that in probably a bit more detail and bring something back to the next meeting of the Leeds Committee.
Thank you. Yep.
Julian's got his hand up. I think it's probably around ERF.
Yep. So thank you. That would be really useful to bring that back. Julian, would you like to come in?
Yeah, thanks, Rebecca. It was just to add to Cheryl's point there. Cheryl, thank you for raising that, because it is an important issue, and it's one that you're absolutely right. We currently have around 7 wards which are dedicated to COVID patients, because we require to keep COVID patients separate to others in order to limit, obviously, spread and make sure that we're adhering to good infection prevention guidance. That does, of course, mean that we're limited to what we can do in terms of the activity on the elective side, added to which the urgent care pressures that Tim spoke about earlier all add up to not delivering at the level that we're being asked to deliver, which is 104% of the 1920 baseline. We're at around the sort of 89%, which actually is pretty good going given those pressures, together with the fact that a lot of our long waiters are complex cases, particularly in spines and so on, which require often all-day operating lists. So the amount of activity you can get through is necessarily limited as a specialist tertiary centre as we are in Leeds. So there's a number of factors here which mean it's not because we're not trying. It is actually the challenge of the circumstances, and the metric that NHS England has applied is a fairly sort of one-size-fits-all approach, which at the moment isn't working for us in terms of recovering that income. So you're right to raise it as a risk, and I'm sure we'll return to that in future meetings. Thanks, Rebecca.
Thank you, Julian. Thank you, Cheryl. And Cheryl, do you want to raise another point, or was your hand up from before? Thank you. Did you want to put your hand down, or did you want to ask it? Right, okay. Is there any further questions on this, or are we able to go to the recommendations? I can't see any indications. So if we're comfortable, can we agree the recommendations, please? I've got Francesca.
Sorry, thank you. Sorry, couldn't get the hand up quickly enough. It's not with an objection, but it is to raise another concern, which I think, in terms of what Tim was saying and Julia was saying about the pressing and immediate concerns and need to address long-term conditions and health inequalities earlier. The third sector in Leeds has weathered the pandemic impact on loss of revenue very well. We're concerned that this might really put some of our organisations at risk, both in terms of their operating costs, costs for staff, and also costs for us, our volunteers and carers who are often working with some of the people who are experiencing the most health inequalities. So I guess the challenge or raising that concern is when we're having those discussions going forward, that we're factoring in those resources and the risk there as well.
Okay, thank you for that. Visa, do you want to come back on that?
I think that's where the arrangements around population boards would help us, because I think that level of intelligence will be fed up through the population boards, because at the moment we don't have a direct line of sight, but that would be the benefit of looking at population groups and having partners on those boards as well.
Does anyone else want to comment on that particular point? Like commissioning third sector stability? Okay, so I can't see any further indications, so if that's okay, we'll move on to the next item, but if we can just approve the recommendations as set out. Thank you very much. Okay, so I'm going to welcome, is it Robert Haken, or is that how we, are you in the meeting?
Hi, Rebecca. Yes, I am.
Would you like to just introduce yourself, and then I'll go back to introducing the paper.
Hi, yes, my name is Robert Haken. I'm Associate Director of Corporate Planning at Leeds Teaching Hospitals.
Thank you. Thank you very much. Very welcome to the meeting. So we're just on item 12. We're going to look at have a verbal update on a financial business case, and I believe you would like us to put a letter of support in from the committee if we're agreeable. So if you could set out the business case, and then we can have some time to discuss. We've got 15 minutes for this item, so if you could just give us an overview within the next few minutes, that'd be great. Thank you.
Absolutely. A few quick slides to run through. I have told the team we need to get through these quickly to give time for questions. So if I just start on the background, hopefully if those have come up. Essentially, the main part of this has come out from the NHS priorities in terms of increasing elective operating capacity and really increasing elective operating capacity away from our acute sites. As we've just heard about the COVID pressure on our sites, what we're trying to do as a organisation is build capacity at our sites where we don't have A&Es, don't get acute flows for. So for those who understand the sites, that is predominantly our Chapel Allerton site, which has currently got orthopaedics and some spinal surgery. There's a separate case which is coming down the line further for additional operating capacity at Wharfdale. But what I'm talking about today is the Chapel Allerton case. We submitted a bid for targeted investment funding for both of those to NHS England through the what was then the West Yorkshire Harrogate ICS. And those two cases were supported. What that has therefore enabled us to do is start to pull together all of our designs for those buildings and also outline business case for the Chapel Allerton scheme, along with a short form business case for the Wharfdale scheme. Chapel Allerton scheme is to create 2 additional theatres at Chapel Allerton, so that's over and above the 2 we already have there, and an additional inpatient ward opposite our existing ward. What we're also looking to do is create what is called an enhanced care area bed. Some previously referred to these as Hobbs beds, so it's essentially a higher acuity bed, normal ward bed and a critical care bed that will allow us to do a higher acuity of patients at Chapel Allerton, both for spinal surgery and for some orthopaedic works as well. We are very keen and planned that those units will be next to and joined to our existing theatres and existing wards at Chapel Allerton, and therefore some of our services currently housed in those, which are non-clinical services, are being relocated into a new build which will be external but still on the Chapel Allerton site. Additional within the case is some extra car parking for the site. We know it's a pressure at Chapel Allerton, so increasing the car parking there for both our staff and our patients when they're accessing that site. That's the overview of the case. In terms of timetable, it is quite a long timetable, but I'll briefly explain that. So we've got approvals to work through over the next 6 months, but realistically the main key bits that are going on now is our design of these new buildings and pulling together our tender documents. What we then actually have is a two-phase construction. So the first phase is to produce that external build to house the services that need to be relocated, and then onto the build for the clinical estate. Strategic case very quickly from me. Essentially, the aim is to start spinal surgery elective operating capacity. I'm sure most of you know the current pressures within spinal surgery and the backlog we have for those patients. This will allow us to provide a sustainable position for that service. It will allow them to increase their operating capacity and allow them to have protected operating capacity up at Chapel Allerton. Significant numbers of our patients end up being cancelled due to acute pressures on our sites, and this will really support, the patient experience, both in terms of a more timely operation and experience on the day of not being cancelled. That's the main element of the strategic case. I'm not going to talk through benefits because of time. And the next piece is the economic case. So this is essentially making sure that the case not only delivers the benefits for the organisation, but benefits for the economy. We are working with PricewaterhouseCoopers to develop that model. We are confident it will deliver the 4:1 ratio that is required of public sector works, and that will be included within the final case. I'm just going to pass over to Richard Noble to talk through the commercial case now.
Hi everyone, I'm Richard. I'm Associate Director for Estate Strategy for the Trust. So I think the key things I want to pick up here is just that there are three main phases of the work. There's the enhanced care areas, which comes first, and we're looking to do in the run up to winter this year. Then the non-clinical developments come next, as Robert's identified, and then the clinical elements follow on from that once we've created the decant. So we're looking to procure it in two elements, one for the fast track element of the enhanced care area, and the other non-clinical and clinical elements will follow on through the Procure 23 framework just been released by NHS England. And we've had positive discussions with the planning department to date around the developments, particularly for the new build and the car park. Obviously, they're key stakeholders. Those are the key parts, Robert.
Brilliant, thank you, Richard. And now Claire and Marie for the financial case.
Thank you. Hi, I'm Claire Gaunt. I'm one of the Assistant Directors of Finance at LTHT. So just to pick out the financial highlights from the case, that there's a capital investment required of circa 26.7 million, which, as you've heard, is fully funded in the Targeted Investment Fund. In terms of revenue, there's obviously a staged approach, as you've heard Robert mention too, around the fact that we open the additional enhanced beds earlier, and then obviously it moves on towards the ultimate scheme when we open the theatres and the additional ward. So in total, the anticipated revenue costs are around 10.6 million, 6.3 million is paid, 2.9 non-pay, and 1.4 million of capital charges associated with the capital scheme. The staffing costs and all the costs have been fully sort of validated, and we've been working to make sure that that's the most efficient model of care for those areas. In terms of the funding assumptions, you've obviously heard about the limited scope for elective recovery funding, particularly after 22-23. And at the moment, we're proposing that the development will be funded through a combination of additional activity and productivity gains and avoiding other costs, but also there are some assumptions in the case about repatriating activity that currently goes out to the independent sector. So that's the sort of the key highlights without going into lots of the financial detail, but they're the key aspects.
Thanks, Claire. Back to Richard for the management case.
Hi, thanks. So just key points again. So obviously we're managing the project in line with the trust standard capital governance processes. That an individual project board for the scheme that reports to our overall elective care programme board, which is running the Wharfdale and the Chapel Allerton schemes, and then reporting into our finance performance committee. Key dates there is obviously when we're hoping for an OBC approval from NHS England in September, I should say NHSE now after the organisational changes. And an early contract award for those enhanced care areas during August time in order to get those up and running for this winter. And that the P23 contractors appointment will be in line with the OBC approval so that we can get moving with the pre-construction works in advance to enable us to build up the full cost for the FBC submission in the start of the next calendar year.
Brilliant. Thank you, Richard. Final slide for me is just a highlight of the workforce model. Clearly increasing our theatre and ward capacity will be required for increased staffing. We've highlighted the key numbers here, but we're confident with the timeline we have to ramp the staffing up that we can deliver that increased capacity, and we're also confident that that can be quite staged, given we're opening the Hobbs beds first, and we have a few other theatre and elective capacity developments in track. So it's all being contained through there, with various different recruitment options and pipelines being explored. That's the end of the presentation. I think. Thank you for allowing us the time to come here. As you said, Rebecca, what we're really looking for is to support from this group, and for a letter of support to go in with the outline business case. What I would say, there's a lot more detail behind this. If anyone from the committee wants additional detail, I'm more than happy to spend that time with you, or I'll get someone else from the team who might be better at it than I am, giving you a very brief overview there, and happy to take any questions now.
Thank you very much for that presentation. That's good to see you all. I wonder if, Julian, did you want to add anything at this stage, or wait for questions?
Yeah, thanks, Rebecca. I mean, just to say, you can see the obvious rationale for this, and given what we spoke about earlier and Tim's point about kind of building for the longer term, we've been under pressure even pre-COVID, particularly on spinal surgery. It's been a speciality under enormous pressure, but we've got a lot of skill and expertise and innovation, and we really want to maintain and develop that centre of expertise and excellence that Leeds provides for the whole of the region. So I guess this isn't just for Leeds, it's for the whole of the ICS and beyond. And this will give us that sustainable future, and it's worth, I think, taking the time to get this right, which the team have obviously done. And this is part of course, a national push on elective recovery, and this is one of the key schemes as part of the available funding nationally for these elective centres, and it's great for Chapel Allerton as well in terms of its role and function. So hopefully you'll see the benefits and give us your support. Thank you, Rebecca.
Okay, thank you very much, Julian. I've got John Beale wanted to come in. If anyone else wishes to comment, ask a question, please put your hand up. Thank you.
Thank you, Chair. Yeah, I would totally support this. My only question is, I guess, to Julian, and that is about recruiting the staff. I mean, we're aware of the large number of vacancies of surgeons, of nurses, of physiotherapists and so on across the NHS. Is there a realistic chance or a realistic probability of being able to actually recruit the staff to do the work which will follow the capital costs?
So the short answer, John, is yes. Given one of the key challenges, particularly for our consultants, is we're fortunate that Leeds has got a good reputation and good clinicians, and we don't have a problem recruiting consultants. The challenge we have is theatre capacity for them, and it's for the opportunity for them to deliver what they need to deliver for patients in terms of that capacity, and of course of all the associated staffing as well, which we're working on. But fundamentally, I think the more we do to invest in the service, the more attractive we are as a centre, and you get into that virtual cycle rather than a vicious one, which we see in other places. So we're planning to build this, and I think it's an attractive proposition for people coming into work, and indeed for people developing through the academy into these roles. Thanks.
Thanks, John, and thanks, Julian. So, Avisa, would you like to come in next?
Yeah, so this is really a question, Claire, it might be unfair, but I'll sort of ask it, and if you can answer it now, that's great, otherwise answer me later. So I can see in terms of the 10 million revenue costs that we've made an assumption around repatriating activity from the private sector, which I think has been part of our longer term strategy pre-COVID anyway, so that follows through with a lot of our joint financial planning. Can I therefore assume that the remainder, where you talk about activity, that it's a combination of specialist commissioning and CCG commissioning activity, and is it just standard growth of around 2% a year that covers it? Or are you looking for more money from the system to be found to deal with the extra activity? And if you can't answer me later.
I can answer some of it.
Yeah, go for
it. I can, and Robert can also add in as well. So there's been modelling done on the activity to look at the backlog and the anticipated growth. So the numbers we've used to come up with the revenue costs assume that level of growth, both normal growth and what it would take particularly in the early years to get that backlog down in terms of the current waiting list issues.
Thank you. So it's a combination of the ERF that will do the early years, and then long term is just standard growth. Thank you.
Yes.
Okay, that answered the question. Thank you for that. Brian, would you like to answer?
Yeah, I think it's building on that actually. It's about, I can see from Julian says it's a no-brainer in terms of you look from the very clear provider aspect and those patients. But I think this committee needs to, in thinking about giving a letter of support to it, needs to think about the resources of the place and how they're committed. And I make no judgment on that. This might be what the place wants to commit its resources to. But just saying it's about normal growth, as if normal growth is just available to be handed out willy-nilly, I think is normal growth handed to spinal surgery on this development, albeit a very good thing, means that that normal growth isn't available for something else. So it is a zero-sum game. If this committee wants to support that growth going to this development, that growth won't be available for something else in the future.
Okay, who would like to respond to that?
Yeah, so if I can, and it's a good point, but so I think what we're being really clear about is that there is an immediate need to deliver an increase in spinal surgery activity and recovery of the spinal surgery waiting list, and that will take us a period of time to deliver. The other part is the long time period we're talking about here. So this is 24, 25 by the time this comes online, and after that, by the time we've got the recovery. So what I think we're all acutely aware of is that, in 2 or 3 years' time, the pressures within the system may be different, and we need to make sure that the development itself is agile, which we have done through design, but that we as a system are agile about what we might want to use it for in 3, 4, 5 years down the line. So, the development, they are theatres and wards that can be used for almost any kind of elective surgery. If you kind of park the highly specialized transplant and things like that need the real high-end critical care. So that we have got that in mind, that this, whilst it's built around spinal surgery now, we know that things change down the line, so it might not necessarily be that 5-10 years down, and that's why we've got the flexibility in design.
Thanks, Robert.
Okay, hey, that's a helpful answer to the question. Happy with that, Brian? Yeah. Okay, Tim's next, and then Sarah.
I think Visa and Brian have covered off exactly what I was going to say, so I'm not going to add to that. I am supportive of this, given the immediate pressures, and I think we do need to support that. But there is some work to be done further down the line about that revenue question, I think, post recovery period.
Okay, is there a mechanism for noting that and bringing that back in, the fullness of time, or is that just going to go into comments that you'll bring back?
I think it'd be helpful. I mean, these are the kind of things we'll need to build into our medium-term financial plan anyway. So that's where we'll start to make some of the choices, the harder choices that we'll need to make, which would include things like this in terms of a longer-term piece of work.
Excellent. Okay, so it's going somewhere and being noted somewhere. That's good. Thank you, Sarah Monroe.
Yeah, a question and just a comment in that last discussion, because that was really helpful. Do we need to then, so the question is, well, does any of this fall within the category of specialised commissioning, because that's a different funding source for LTHT as opposed to what we get through the ICB? I think it'd be great if it was. But secondly, with that other point then, if this is about us needing to think about the longer term costs from the lead pound, then I suggest we need to put some caveats around that level of commitment so that we're not tied in. I think about some of the other
exponential growth in demand for other services such as ADHD, such as autism services, and I'm sure there are others that Brian has. When you're making recurrent investment decisions on isolated business cases without understanding the totality of what that population needs, we do not yet have that degree of maturity across our population care boards to start chunking stuff off in this way, and potentially then restricting what we've got available to us in subsequent years when we're, if you think about the shift that we're talking about in the system into community services to reduce demand on beds, there ain't going to be huge pots of money coming our way in future years.
Okay, thank you for that. Visa, you had your hand up before, but you've taken it down. And Chris, could you verbally comment as well? As I've seen you put something in the chat, but if you could say, we could then discuss it. Visa, sorry, Visa, did you want to go first?
It was only just to say, all your comments and caveats we can put into the letter of support. So what we could say is that we definitely will underwrite the capital charges, for instance, because you're going to have to go and build it, but the revenue costs of the services, etc., might be dependent on what services we'll need in 2025 or what specialties we want to invest in. Could be something like that, but I'll have a think and maybe run it past a few people.
Thank you. Thanks. And Chris?
I think Sarah said part of what I was going to say, that these capital investment pots encourage us to be innovative around buildings, and LTH is being fantastic at drawing in hundreds of millions of pounds into the Leeds economy on doing this. It does have a knock-on impact, but in terms of building community capacity and the things we need to put in place to look after frail older people as they come out of hospital is probably actually best done in their own homes. So we can't build shiny new facilities that attract innovation and staffing in the same way. And it was just a challenge to us, I guess, to think about things like this that might just add a little bit of punch into community transformation. So it was more just musings rather than any specific comment. But I think it's great to see the buildings, but equally we need some big impact on community development and services, which will help out the hospital in other areas, and more importantly, better outcomes for frail people. Thanks.
Thank you. It's really a good discussion. I just want to say about the chat is that if we could speak, verbally discuss it rather than put it in the chat, it would be helpful, because this is being recorded so people can watch it at a later date. And some of the wording that's being used is sort of acronyms or language like that. So if you could just verbally update, that'd be great. So Robert, you were next.
Yeah, sorry. So to come back and cover, so I put it in the chat, but so roughly 50% of this is specialised commissioning work. So we're engaging with specialised commissioners as well on those activity. And Chris, I know it's small gains, but they all help. The way we are setting up the ward within this new unit has got kind of therapy and elements like that at the heart in terms of re-enablement, in terms of efficiency. So I know there's a whole host of other stuff that we all need to do to deal with the frail and unwell, but we're really keen to make sure new things that we put in support that direction of travel rather than kind of make them worse. So they are in there, but I appreciate that's the tip of the iceberg of what we're trying to do as a city.
Okay, thank you. I've got Julian, but Visa, was your point on that specialised commissioning? Do you want to come in next then?
Very quickly to say, yes, just to be aware that specialist commissioning budgets are coming back down to us to manage from next year anyway, so it'll be for us to sort out from that as well, but we'll have a bigger budget. Okay. Thank you. It's good to hear that future plans are taking into account citywide, priorities and flexibility from an independent member's point of view. I think that sounds good, and good to hear there's assurance going on as well. Julian, do you want to come in?
Yeah, it was only to say quickly, we must watch this delegation of specialist commissioning to both the ICS and indeed our place to make sure, particularly in our case for Leeds, given the sums involved, that delegation doesn't fragment and mean that actually we lose out as a place, and it'll be the same in mental health commissioning, it'll be the same in other areas where traditionally, and indeed moving forward, we account for the vast majority of the whole of West Yorkshire's specialist commissioning, and therefore it's hugely important that that delegation piece is done in the way. Otherwise, you know, we create risks for ourselves. Second point, Rebecca, is I agree entirely about the points around the wider healthcare factors. It would be great, wouldn't it, if we didn't need to do these things in terms of the number of patients that need our attention from spinal surgeons. So I guess it puts the focus on our whole health and well-being, active lifestyles, pathways for musculoskeletal, the opportunities actually as a place we have to bring together some of our teams in physio and OT. And we should probably challenge ourselves to do that, to see where economies of scale and scope exist and benefits for patients accrue in terms of those teams working in a more integrated fashion. So some things for us to, I think, mull over as a consequence, but appreciate what I'm sensing is the broad support we've got for this, and recognise some of the kind of individual points that colleagues will want to go into a letter of support. But thanks for the chance to air it.
Okay, thanks, Julian. That's helpful. I've got Yasmin, and then I think if it's okay with the meeting, we can move on after that. Yasmin?
Yeah, I think really useful information, really helpful for me as a newbie. Just wanted to check, I think we touched on earlier around, Tim touched on this around being important and urgent. And I think this, this is both of those. I think it's really important, but it's also urgent. So really support that, the proposal. I guess for me, I'm just looking at listening in around some of the risks around making sure that I think we had John touching on around staffing. I know that Leeds does attract, I agree, the talent, but then again, it's about all our infrastructure, in terms of, if we refocusing our priorities, changing our priorities, is there risk to something else that we've, are we going to impact another area in terms of infrastructure? Because I guess for me, when change happens and new things come in, we rely on the resources of existing people, and then the impact of that is, burnout for people because we haven't been able to do that. So my question is around infrastructure. Are we going to get once the funding and things are in place, is the infrastructure going to be fit for purpose?
Who would like to come back on that?
So, so by infrastructure, do you mean the elements around Chapel Allerton? Sorry, I'm just not quite sure I understand the question.
The Chapel Allerton, yeah.
Yeah. So, and I might bring Richard in a second. Yeah. So clearly improving the external areas of Chapel Allerton in terms of car parking, but as part of our planning application, we will also need to do a travel and transport plan. So, that will also support people accessing the site. I don't think there's any wider investments, no wider investments from us in terms of around the Chapel Allerton site. I think that would be something we'd have to have conversations with the council about. Richard, have I missed anything there?
No, I think that's covered everything, Robert. Thanks.
Okay. Well, just on timings, it'd be useful if we could wrap this item up and get to the recommendations. If that's okay with everyone. Have we covered all the issues that we need to raise? Does anyone have anything else burning that we haven't discussed? Yasmin, have you still got your hand up? Okay, thanks. So we are asked to offer a letter of support from the committee. I haven't heard anyone say no to that, so I'm assuming we're happy to do that, with the caveats that Vita suggested could be put in the letter. How do we want to approve that, the contents of that letter? Should we delegate that to Visa? Yeah, I'll delegate. Yeah. Okay, put your hand up to be delegated to. Yes, are we comfortable with that? Thank you. Got some thumbs up. Lovely. Right. So we've approved that. So we can move on to the next item if that's okay. All right.
Thank you, everybody.
And thank you for coming. And that sounds, very positive and good to have some more infrastructure with those caveats. So thank you for coming.
Thank you.
Thank you.
Thank you. Right, so just thinking of the time, we've got a few items here that are about items to the attention of the Integrated Care Board. Then we've got our forward work plan and some summaries and reflections. After that, we've got any other business, and I know we've got 2 or 3 items of any other business. So I want to give a few minutes to that. So if we need to sort of look at our forward work plan and items to the attention of the Integrated Care Board and our summaries and reflections for this meeting, sort of within the next sort of 10 minutes, really. So in a way, summarising the meeting and having some thoughts and reflections about it might help us to put something together for governance to present to the Integrated Care Board, which is the next item. So we have to give assurance to the Integrated Care Board on items that we have discussed and considered. We also, having taken on this role, a lot of discussions about risk and assurance, but also we need to think about positive things, in my view, that we can share with the West Yorkshire system. So if we could just, if I could ask Tim and Sam, if you want to reflect anything from the meeting that you think might go in that report. Thanks, Julian. I've got your message there. Then we can just get agreement from the meeting, hopefully, about what we'd like to put in that report. Tim, do you want to do that, or Sam?
I think we need to note the conversation around the pressures, and that we'll come back to review that in September. I think that is important. And also I do think the Chapel Allerton piece, given how important it is around elective recovery. I wonder whether there's something to share, and I think Mel is still on the call for Wakefield because she's joined us just to observe today. I think there's something really positive about the way the people piece at the beginning, both the story but also the conversation about how we want to embed that and how important that we see that. So those are my sort of 3 initial thoughts, I suppose. I'm sure there are others from other people, but those would be 3 that I think we should touch on.
Can I Sam, are you about to come in? I was just going to ask.
Oh, sorry, Rebecca.
No, I was just going to ask Kath and Victoria, just from the Council Social Care Public Health side, if there's anything that they would like to sort of reflect on from the meeting as relates to their, aspects of their role in the council.
I think for me is I need to get my head around the detail of NHS finance, because I'm reasonably good at reading a budget sheet, but understanding your budget sheet was quite hard. I think I might need a tutorial from Visa so I can properly contribute.
I'm with you there, Kath. I've said exactly the same thing a few times, and I'm having a meeting with Visa to get the same thing. But in terms of system pressures or what it's like for you at the moment in social care, how's that feeling?
It's incredibly pressurized, and it's not just system flow. It's thinking about the year ahead. We're just doing our fair cost of care exercise. We've got social care reforms to implement, with probably not enough money to deliver the policy objective. They also have significant workforce implications, and we can't secure enough workforce now, never mind try and find 53 more social workers to do all these assessments of self-funders. So it just feels in the round for health and care a really, really pressurised moment.
And Victoria, is there anything? Are you still with us, Victoria? Yeah. Is she gone? Oh, possibly. Okay, so Sam, what did you want to come in?
I was just going to say that I'd written 3 things down, which were system pressures, the business case around Chapel Allerton, and the positive discussion about we start with people. So me and Tim have aligned those without even knowing about it.
Excellent. Well, I think it would be really good to add in the social care pressures as well, given that it is an integrated system of health and social care, and the Department of Health and Social Care. We need to talk about the pressures on all of the parts of the system if we're sharing that. So thank you for raising that cap as well.
It looks like
Victoria's just come back.
Yeah.
Ah, Victoria, are you with us?
I am, yes. Can you hear me?
Yes, we were just getting reflections and what it's like for you at the moment in the sort of council work and public health and social care on just on system at the moment, and if you'd like to share anything that you'd like us to share with the Integrated Care Board at West Yorkshire as well.
Sorry, Rebecca, the meeting just threw me out, so
Oh, what a shame. Okay.
I missed the last 5 minutes, so I'm sorry if I've missed the run up to this conversation.
Yeah, no, we were just talking about item 13, but we're sort of putting it together with item 15, which is summary and reflections on the meeting, and then items for the attention of the Integrated Care Board, which we have to sort of share things with them for their assurance about our system. And I'm just conscious that we talked a lot about NHS finance and pressures. So I've asked Kath to talk about social care, and I just wondered if there was anything from public health you'd like to share about how it is for you in the system at the moment.
Yeah, thank you for the opportunity. I mean, I think that it'll be really interesting to kind of see how the new arrangements work by the fact that we've built in this local sort of join up to the local public health system. So that feels like a real opportunity. I think that you know, there's a whole load of things happening that are very real and challenging, but with opportunities as well at the moment. So for example, we were expecting the white paper on health disparity this Monday, the 11th of July, and we were all lined up for government briefings until the chaos in number 10 completely disrupted that. So, which is a shame, because actually there's some really critical we were expecting some quite critical content of that health disparities strategy, some of which would feed into the work of this committee. So we're having to kind of hang on for that now because of all the political upheaval nationally. So I think that's one to just be cited on. Because I think there's a real trick on how we line things up. So one of the things that were some of the themes in the white paper were around the challenges of obesity and how that's playing out in the post-pandemic, really across population, which chimes with a lot of the pressures, for example, that are coming down NHS routes. So there's also something in, you know, lots in there around older people, children and young people, cost of living pressures, and particularly leading up to what we know is going to be a challenging winter. So I think for me, the main sort of golden opportunity really is to make sure that we join up everything that comes down kind of streams in my world, really, in local authority public health, which completely relates to being part of helping manage the pressures that we've talked about nearly all of this board today, and how we make sure that's completely joined up as well as it possibly can be with all of the things that come down NHS lines, because we know that nationally that doesn't join up too well, but we've got a real chance to do that locally. So it feels like that's the kind of golden challenge, really, because we've not got, and all of this is within the context of shrinking resources and, you know, further pressures on us all financially. So, you know, I think the real challenge is how do we make that, you know, real limited resource get to the parts of the city we really want it to get to, not duplicate, join up as well as we can. So I think that there's been a lot to go on in this meeting today, which has been really relevant to that conversation. But I think as we go on as a committee, there'll be a test really on how well that's working, and I think to check we've not got different silos of work across different organisations. So thank you, Rebecca. That's what I wanted to say.
Well, it's lovely to have an integrated committee, isn't it? So we're going to try and pull things together that are perhaps not as pulled together. It's such a complicated system, so we need to sort of keep on with that. So I wonder if then we could circulate an email to members of the committee, Sam, to get reflections on what's worked well, what's perhaps what any ideas for future meetings, and as well as that, circulate the work plan and ask for items to put on the work plan for going forward. We've already talked about system pressures going into the September cycle, and it'd be good to hear from social care, public health, how anything housing, anything relating to health and care, as well as the NHS in that as well. I'm assuming that public health, social care, NHS people are all on our programme committees as well, programme boards together. So that should pull together the joint working there, shouldn't it? And we should get feedback about that, which is very exciting. So in that case, perhaps we could go to any of the business now, Sam, unless we haven't quite covered all the items off. Are we happy with that?
Yeah, I think Melanie had a hand up. I don't know if you wanted to come in, Melanie.
Yeah, I didn't know whether I just missed the opportunity.
Oh, sorry,
so don't worry, Rebecca. If it's...
I haven't got your hand up. Sorry, on my screen. Apologies. Go for it. Yeah, go for it.
I just wanted to say thank you to the committee for letting me observe today, and I've stolen a wonderful idea with your approach to how you follow the patient experience journey. We haven't adopted an approach where we're recording people's experiences over a period of time, so I'd love to take that away and take that forward in Wakefield and get our Health Watch colleagues to connect with Health Watch Leeds. So thank you. And it's looking at your agenda, I don't know if it's helpful to know this, but I was really surprised because we've almost got an identical agenda on Tuesday in Wakefield when we have our committee, and we haven't organised this together with Samantha. It's a coincidence. Some of it I know everyone has done in terms of adopting our terms of reference, but we've got similar health inequalities conversation, and some of the areas you've considered today are on our agenda as well. So thank you for letting me observe, Tim. I really appreciate it.
Thank you very much. Thanks for those comments as well, that feedback. That's great. And it's lovely to have people from the rest of the wider West Yorkshire here with us as well. So can we, Sam, is it all right for us to go to any of the business? Have we covered everything off? Good. Okay. Yeah. So there's 2 items about any of the business, or 3 even. Sam's got one on the MOU.
Yeah, so the MOU is on there for items for information. It has been going through partner boards for sign up. I just wanted to make members aware that there'd been a slight omission in that we hadn't sent it through Health Watch. So John, I know you were copied into those emails, so I've arranged with Hannah that that's going to go next Thursday, and then they'll be added to the signatories at the back. So I just wanted to make sure that the committee were aware of that.
Yes, thanks Sam. It's on our agenda for the board meeting next week.
Great, thanks John.
Okay, and Visa, did you have, I think, 2 items? Do you have?
I had, well, I can remember one, but remind me what my second one is.
I'm not sure. I think there was a third at the last minute. Sam, maybe I made that up.
Right. So just Sam, remind me what the second one is. But the first one that I was going to raise was, we've talked a lot today about system flow and the pressures at LTHT. There is a system-wide piece of work that's happening, for which we have some consultancy support. Now, we did the first phase of it, and it was it didn't cost us over the threshold of £50,000 to do it, and we did it very quickly, which culminated in a presentation that we did to Julian Kelly, who's the who's the finance director for NHS England, and Matthew Wynne, who I think is performance, if I'm not wrong. And they were both very pleased and very impressed with our plans, the phase 1, the phase 2, and the phase 3 that Tim talked about earlier, and recommended that we go ahead with the next phase of putting through a programme board and doing the 3 phases of the next six weeks, is it 6, and then 6 months and whatever plus. It's too late in the day for me to remember things. So what I've done is I've submitted a business case to NHS England, which I've just had acknowledgement today that they are processing it. We need to approve it because if it's between 50,000 and 250,000, we have delegated authority here in Leeds in this committee to approve it. So I've submitted it in advance. If we get approval, I've also put expressions of interest on the portal. So I've had so far 2 people who've said they're interested. So we will get bids for it. One of whom might be somebody who did the phase 1 work for us as well. So it's just what I'm asking is for people to endorse that. I'm happy to share the business case with anybody who's interested, or Sam, you can probably send it out if you want, because it'll be a public document anyway once it goes on as on the tender process. But it's just to say, because of the sort of change from CCG to ICB, it's just business that's struggling over the 1st of July.
Okay, so you're wanting us to approve that just now for you?
Yeah.
By nodding, that's fine.
But bearing in mind, we're still waiting for NHS England to approve it, so we may not get approval. But if we do, it's just to say it's what. Sorry, what I did do is I asked the chief execs of the 4 NHS organisations to give me the approval on the basis that I couldn't get this from this committee in advance. So I've had all 4 of them support me, or all 3 of them, myself being the 4th. I gave myself approval on behalf of Tim.
Okay, I think part of us, those of us who are not, you know, au fait with NHS finances, I do sort of feel that we need those briefings, I think, to get up to date with it. But I think you've got nods around the table here, so this virtual table. So yes, thank you very much for raising that. Any other comments on anything that anyone would like to raise? Can't see any points. And in that case, I would like to thank you all for your attendance and participation in our first meeting of the Leeds Committee of Integrated Care Boards. It's been a really interesting meeting. I think we've covered a huge amount, and apologies for having to race through some of it in order to finish on time, which is at 4:45. I think it's been really useful. I found it very interesting and good to see you all. The next meeting will be held at 1 o'clock on Thursday, the 22nd of September, hopefully in a public venue, but obviously COVID related, hopefully we'll be able to meet up by then. So thank you again and enjoy the rest of your evening, and lovely to see you all, and take care.
Thanks, Rebecca.